late than never. And again, thank you so much for joining us.
Thank you so much, Dr. Osman, for the introduction. That was so generous of you. I'm like, I don't even need to do my About Me slide. I appreciate that. So I'm going to share my screen and do it anyway. Welcome you all to this presentation today about neurodiversity, specifically about ADHD and autism and how folks get missed. Give me just a second to share my screen. Okay, so for a second, it'll be sharing the desktop. Please forgive me. Okay. And that just shows you like how like not tech savvy I am. I'm like right in the middle of the generations of like, I should know a little bit, but like not really. Okay, so hide floating meeting controls. Okay, so how did I get missed? So Dr. Osman shared a lot about me already. One thing that I wanted to highlight is I don't just work. I do also have a family and life outside of my private practice in psychology. I am the wife and mom of ADHD and autistic brain styles. And for this presentation, I'll be using interchangeably identity first language, like a person with ADHD and identity first language, like autistic person, and then person first language, like a person with ADHD. Typically in the autistic community, it's like identity first. This is, you know, who I am, this is how my brain works. And so I try to respect that, but force of habit, sometimes I use person first, which is what typically allistic people, so non-autistic people try to do. But that's where we are. So what are we going to learn today? I'm going to share with you guys the latest diagnostic criteria from the DSM-5 for ADHD and autism, describe the features of both, and AFABs, or folks who were assigned female at birth and twice exceptional individuals, and why those in particular have a higher rate of being missed and why that happens. I'll also share with you guys a couple strategies that clients can use to manage the challenges that come along with neurodiverse brain styles. But you know, most importantly, I try to use a strengths-based perspective. You know, there is a reason why there is such a high rate of neurodiversity in our population. There is a genetic and evolutionary advantage. And so I try to highlight some of those things within the presentation. I did share this quote from Dr. Laura Hannes-Webb in the ADHD Teen Webbook. This is an open source resource for you guys. You can just download online or from Attitude Magazine. And she says, people with ADHD, and I said like, and autism, have unique sets of interests and skills that they're passionate about. And the place where your passion meets your purpose is your sweet spot. And if you can live from your sweet spot, you can become very successful in life. So this is really about understanding that, yes, there are some inherent challenges like executive functioning issues that come along with both aspects of neurodiversity, ADHD, and autism. But then there are also some beautiful gifts and strengths that, you know, when you find how those two combine, or, you know, managing the challenges while honing the gifts, you can really live a very fulfilled life. So I'm gonna not really open the polls, but I'm gonna figure out how to see the meeting chat again. And what I'd like you to do is private message me in the chat your response to these myth versus fact, okay? So give me just a second. Okay, so number one, and why I say private message is like, I want like full disclosure of what you really think about these questions without any risk of like pure colleague embarrassment if you're wrong. So go ahead and share with me your answers to number one. And it's just true, false, okay? One core feature of ADHD is that a person cannot pay attention. Is that a myth or a fact? Okay. Okay, so I had most people say myth. One person was like, yeah, sometimes. So that is actually a myth. And I think this is something that we want to get clear around in the language around right away. So ADHD, or attention deficit hyperactivity disorder, even though even in the name it's misleading, attention deficit, it's not that you can't pay attention to things. It's an inability to control where your attention goes. So for example, if you're in the room with a client and you're blessed to have a window, I don't in my office here, and there's a bird that flies, up to the window. Both of you guys, assuming that you're neurotypical, so not having ADHD, both of you guys are going to look at the bird. However, the person with ADHD is going to have a much more difficult time bringing their attention back to your conversation or your session because there's less control over where their attention goes. You also see this if you've ever heard of someone having hyperfocus, like one of the superpowers of ADHD. Like they can definitely pay attention to whatever their special interest is, or video games, or whatever the case might be. You see this a lot in kids, like, oh, okay, you can't do your homework, but you can do like Minecraft for 5 hours, right? Because it's a matter of controlling attention. Number two, one core feature of autism is that a person does not care about the feelings of others. Myth or fact? Okay. So we got a unanimous myth. Yes, 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 yes. So you guys have not fallen for the last 30 years of media messages that say that autistic folks are like sociopaths. That is not the case. That is not the case. What you see instead is that an autistic person may miss social cues. So they may not have, understood organically that, oh, I just, hurt this person's feelings by speaking very directly. But once they know, they feel very deeply, very, very deeply. And so it's not about not caring. It's about, being able to pick up on those cues and nuances in social communication. And that's where some of the support comes along. Number three, we have 6 of these, 6 or 7, I think. Okay, so number 3, I'm having fun with this. I hope you guys are too. The only way to diagnose ADHD is with a neuropsychological assessment. Myth or fact, true or false? Okay, so we were about split with this one. So some people said false, some people said true. That is false, actually. You as counselors, as therapists, can diagnose ADHD. You look at the DSM, you say you got these diagnostic criteria, you can give some screeners. The pediatrician, or the primary care can diagnose, the psychiatrist can diagnose, you as a mental health therapist can diagnose. However, some people, yes, someone says like, but not really comfortable in some cases. Yes, that's where it's like, I don't know. Because the one thing that comes along with diagnosis is the differentials. Like, okay, well, is this commonly a differential in adults is this ADHD that I'm seeing with the emotional reactivity and dysregulation, or is it bipolar disorder? Or in some kids, is it ADHD, or actually not kids, but everyone, or is it executive functioning issues? So ADHD type symptoms, having a hard time getting started, having a hard time finishing things, not being organized, along the way, all those sorts of kind of higher level executive issues. Is that secondary to depression? Or is it secondary to anxiety? Or do they have both going on? So that's where a more formal assessment can be helpful to help differentiate if there's multiple things going on. But yeah, you don't need it. All right, number 3. Number 4. The only way to diagnose autism spectrum disorder is with the ADOS, or the ADOS-2. True or false? Okay. So everyone said myth. I would love for someone to take themselves off of mute and share why you said that this is false or a myth. Any brave soul? I'll wait. Okay, go ahead, Van.
I don't know if this is true, but my guess is that most likely because it was designed by somebody who's not part of the community, who has these check boxes as to what autism may have been perceived by this individual or individuals, but it erases the reality of many people who are masking or overlooked.
Come on, yeah. They got it. Yes, exactly. So, the ADOS is considered the gold standard. It's been around for the longest time. They've, poured a lot of money, my own bias, into, advertising. But the kit itself is like $4,000. And then you spend, another couple thousand to get training. Mind you, I did that because I was like, okay, I got to hop on the bandwagon. But there's also something called the MICDAS, which is the Montero interview guidelines for the diagnosis of autism spectrum. And it also looks at interviewing and observation of behaviors. And it is normed on a population that is wider, where it's more likely to pick up on people who are masking because they have higher intelligence and people of color, where the ADOS will often miss folks who are, within those populations, especially folks who are, higher IQ. So yes, it's not just the ADOS. And then there are a variety of other screening and symptom inventories and, formal interviews and things like that. Research-based normative sample-based interviews is what I mean. Okay, number 5, we just have a couple more. 75% of people with autism have a co-occurring mental health disorder, and almost 50% have 2 or more. Fact or myth? True or false? Okay, so most of you guys knew that this was true. It's a difference in the brain wiring, but really it's about the lived experience of being neurodiverse in a neurotypical and ableist society. And I imagine maybe the US is better than some other countries, but I mean, we have a far way to go to make our society more accepting of different brain styles. So when you see anxiety pop up, when you see depression pop up, when you see other things that show along with ADHD and autism, think about how traumatic it is to say, for example, and this is kind of an analogy that's off to the side, to be left-handed and made to use right-hand scissors and made to use right-hand notebooks that hurt your wrists because that's where the spirals are. That's, just kind of a far-reaching analogy to living neurodiverse in a neurotypical world. Similarly, number 6, 75% of people with ADHD have co-occurring mental health disorder, and 60% have 2 or more. Fact or myth? Okay, you guys got that? You guys got that resoundingly. You're like, okay, I know the path that Dr. Blied is heading on. She's trying to like educate us in the whole presentation within the first slide, and then we're done. Okay, last question. Executive functioning challenges are a feature of both ADHD and autism spectrum. Myth or fact? True or false? Okay, so most of you guys got that yes, that is a fact. So the majority of people, and I don't know the specific percentage, do have executive functioning challenges. And so that's why part of the support or the resources that are provided for people with both ADHD and autism are executive functioning coaching or some sort of executive functioning skills training. All right, awesome. You guys did so great with that. All right, so let's start with definitions, just so that we are all on the same page. So what does it mean when I say neurodiversity, neurodivergence? So this is the concept that there are differences in brain development, such as ADHD and autism. Also within that spectrum is, or within the definition is like learning differences, so learning disorders. And they're natural differences that should be accepted. So like differences in hair texture, eye color, skin color. And it's important to understand that like it's a natural variation in genetics, so that we can accept ourselves and accept other people instead of trying to change them or trying to, you know, make them feel like something's inherently wrong with them. It's not. Neurodivergent, if I can get to the other side of the this screen, it's also used to describe people who have different or atypical brain development. And again, all deserving of acceptance and respect. So just because one brain functions differently or picks up on different things than someone else doesn't mean that one is right and one is wrong, because as there are many different types of flowers in a field or fish in the sea, like they're all needed. We are all needed to make this thing called the human race work. All right, so what are the diagnostic criteria for ADHD? So 6 or more symptoms of inattention or hyperactivity for at least the past 6 months, or 5 if the person is an emerging adult or older, so 17 years and older, in 2 or more settings. So it doesn't just happen at home or just happen at school. It's like school, home, social settings. And the reason why it's inattentive or hyperactivity, because there are different presentations, is what we call them, of ADHD. So you can have ADHD inattentive presentation, ADHD hyperactive impulsive presentation, or ADHD combined presentation. So this is different than the DSM-4 in previous, where it was ADD. So attention deficit disorder without the hyperactivity, or ADHD. Now everybody's ADHD, and it's just what presentation you have. And this is a neurodevelopmental disorder. So it's important that there are some signs that are evident before the age of 12 years old, although recent literature is more pointing to like, actually the DSM is probably a little bit antiquated, where there is late onset, so around 15, 16. But what I'm seeing in my practice is that folks are often noticing around 14, 15, 16. So in high school, as things get more difficult academically, as they have more leeway and freedom, and less kind of like the parents making them do everything and providing so much executive functioning support, they're noticing the differences in their brain styles. But those features were there from oftentimes like kindergarten, 2nd grade. So part of my assessment is I go back and look at report cards starting in preschool all the way up to the highest level of education completed, and reading all the teacher comments, reading things like keeps forgetting to turn in homework or get their paper signed, or a messy desk, or talks too much. Like, these are all signs that the ADHD was there all along, but often they're ignored if the person isn't like literally climbing up the walls, or if the person is getting decent to better grades and they're like, oh, they're fine, they're just a little fill in the blank. So how does ADHD show up? Like, why is it so prevalent in the human race? So what does it look like? So it is a difference in the biological functioning in the brain. So we talk about the chemistry and the structure and the wiring. So it's so complex, and neuroscience doesn't fully understand, but we do have some clues. So there's differences in the chemistry. So two key neurotransmitters, dopamine and noradrenaline. Dopamine is what we know a lot about as far as that being the reward chemical. So when you feel rewarded, you feel motivation, and there's often a lack of motivation to attend to things that aren't interesting to you for the ADHD brain. And then there's also differences, again, like I said, in the brain structure itself. And I have those listed on this slide: the frontal basal ganglia areas, the supplemental motor area, so the ability to like not be always on the go or driven by a motor, that impulsivity. The prefrontal cortex, I talked about that with like executive functioning issues. The cerebellar area is our sense of balance, but then also in the cerebellum is some of our autonomic functioning. So like our heart rate and our sweating and, all those things, our breathing rate, all those things that come automatically. And the differences results in, again, differences in impulsivity, attention, and executive functioning. And I mentioned this already. It's about the ability to control where your attention goes. It's not about willpower. It's not about willpower. I'm going to say it a third time. It is not about willpower. And I think once we as mental health therapists understand that and can share that with parents, or even share that with our adult clients who we're working with in the college counseling setting, there's so much liberation that comes along around that, because no longer does a person feel like, oh, I'm just lazy, or oh, I'm just stupid, or oh, why can't I get it together? Because it's about your biology. Like, trying to like, punish yourself for a pancreas that isn't, producing enough insulin. That's ridiculous. We would never think that. We would just give that diabetic child some insulin, we would treat the diabetes, but for some reason, when it comes to our brain, we are a lot less gracious. We are a lot less gentle when it comes to anything mental health. And so if we can start to change the narrative and the script so that people understand the biology, they can have a lot more compassion for themselves, and their support is going to look a lot different, a lot more helpful. By the way, heritability is 76%. ADHD is as heritable as height. So if there's a parent with ADHD, very likely the kid is going to have it. Not 100%, 76%, but that's pretty damn high. Okay, and so I wanted to share, and I'll share later about the spectrum of features for autism, but there's also a spectrum of features for ADHD. And so when we think about spectrum, I don't want you to think about it linear, as far as like, if you're here, then you're high functioning and you're getting good grades and nobody can tell that you have ADHD. And if you're here, then you're low functioning and like, we need you in, remediation or whatever. That's not it. It's more like a pie, and there are different slices of the pie. And within those slices are, strengths and challenges and how much support you might need. And so that could include issues of motivation, impulsivity, sensory issues, either sensory seeking or sensory sensitivities, attention, memory, some of the flexibility and thinking, some of these go along with executive functioning issues. This I just pulled off the web, but I like this on the right side here that goes more along with the diagnostic criteria of like impulsivity, emotional dysregulation, forgetfulness, hyperactivity, the things that we actually see. So here on the right side is my personal spectrum of ADHD features. You see there's like a lot of inattention. Don't tell my husband about emotional dysregulation. He probably already knows anyway, but not so much hyperactivity. And that's typically what you see in adults anyway. They have more of an internal restlessness, but they're not necessarily always getting up from their seat because socially we're shamed, from doing that. So we learn pretty early. And things like that. Developmental delays. It was, I was today years old, but it was just like several months ago when my 2-year-old was having her evaluation that I learned that expressive language delays actually show up in ADHD, not just in autism. And so I was like, oh, but the difference between those developmental delays in autism versus ADHD is typically with ADHD, there's a gap in expressive language. So, speaking. However, once it does finally pick up, it follows a normal trajectory. Versus in autism, there may be a delay or there may be no delay, but typically around 18 months or so, there's actually a regression in skills. And then it might, follow along a trajectory. I'm not looking at the chat. So if there are questions that come up, please do let me know.
Would you like us to ask questions in the middle,
Yes.
or would you prefer that we wait until the end?
Yeah,
okay,
ask questions as we go along.
Van has a question.
Yes.
So I had a question about ADHD, and this isn't about like training somebody to be different. It's a question about somebody's like survival, if it's possible where they're missed. Can somebody with ADHD mask having ADHD by either hyperfocusing or looking like they're hyperfocusing, kind of like you said, like we're shamed into not getting up from our chairs. So because you said that it's not willpower, which I get, but I was just wondering if there's a way that like with enough training that somebody goes under the radar because they've like trained themselves to look like they're focusing.
Yes, absolutely. Train themselves to look like they're focusing, train themselves to look like they're not hyperactive, train themselves to not interrupt people while they're talking. So like in their mind going like, don't say anything, wait until they're finished, like, all that. And I'm going to talk about that a little bit later when I have the diagnostic, not diagnostic, but the case examples of when people get missed. So, when I say like, it's not about willpower, it's kind of like what people label as the bad behaviors. Like what I'm saying is like, people aren't doing that on purpose. They're not being spiteful and manipulative. Like, you know what? I know that you're telling me to go and take out the trash, but I'm going to forget it again. It's it's not that. It's like, it's a literal like, not attending to what was just told to them. And so it may just like fly through instead of being stored in the memory. But yes, people do, are socialized to behave or to fit in, especially those who are assigned female at birth. That's taught like immediately. Okay, so DSM-5 text revision updates to autism spectrum. So I told this during the last presentation. So I bought the DSM-5 text revision. So this big old $200 thing, because I saw on, and now it's a computer prop, because I saw on, that was disrespectful, take that out of the recording. But I saw on like some forums that there was an update to autism spectrum. So I was like, okay, like obviously diagnosing autism, like I need to know what it is. And so I had my DSM-5 and my DSM-5 TR, and I'm going like through every criteria. Nothing's changed. So this is what it is. Okay, so persistent deficits in social communication and social interaction, again, across multiple contexts. So not just at home, but homeschool, with peers, as manifested by all of the following. So all three. Deficits in social emotional reciprocity. So being able to have that back and forth or reciprocal of showing whatever that person is showing. So like, oh, if that person's sad, like, getting in it with them. There's a typo in here, but it's supposed to say nonverbal communicative behaviors used for social interactions. So early on, that may look like the person, not waving goodbye or nodding their head for yes and shaking their head for no. And it looks a lot different for someone who is a lot older. And then developing, maintaining, and understanding relationships. A lot of people are missed later on because they have friendships. It's like, oh, you can't be autistic because you have friends. Like, how much work is it for that person? And how much did they have to study and learn scripts in order to understand the relationship and the different dynamics within it. And then part B is restricted, repetitive patterns of behaviors, interests, or activities as manifested by at least two of the following four. So this could be stereotyped repetitive motor movements or repetitive speech or use of objects. Early on, that looks like dropping a ball from the same height over and over again, or echolalia, which is, saying the same thing that someone else has said or they've seen on a movie over and over again, but in a very stereotyped way, like, boom, I got you. Boom, I got you. It's like, okay, like we're talking about, baking bread. Like, what does that have to do with it? Insistence on sameness, inflexible routines, ritualized verbal or nonverbal behavior. This is where a lot of folks, especially assigned female at birth, are misdiagnosed with OCD. And this is also where folks assigned female or both, they get like the alphabet soup of diagnoses. It's typically OCD, PTSD because trauma, restrictive eating disorder, and I can't remember what the last one is, but it's just like there's a lot before people are just asking the right questions as far as like, actually, what is this like for you? How do you know like who is a friend? What do you guys do in those sorts of particular questions? And then either hyper, meaning too much sensitivity, or hypo, meaning being sensory seeking because not enough sensitivity to sensory input, or unusual interest in the sensory aspects of the environment. So I had a client where he really thrived in being in nature, and he would notice things in nature that like I wouldn't notice, or people typically wouldn't notice. So like he would notice the hoot of a particular owl, and he knew like the species and all that stuff. And he would, notice like the dew on the leaves and like all these really beautiful, miraculous things. And I even noticed that in my husband when he will share about like his feedback to me doing like a recording or something. He's like, yeah, and when you're really into it, you get like your Black preacher voice on. And I was just like, wait, what? Like, where your tone kind of speeds up and then it slows down, and then you really get into it where, these and those things. I'm like, wow, like, I mean, I'm just doing my thing, but like, it's cool that you notice those specifics. So present in an early developmental early developmental period. So, there's some signs early on, and with like the ADIR, the Autism Diagnostic Interview Revised, which is for parents, we ask a lot about the ages between 4 and 5 years old, between the 4th and 5th birthday, because that's when people typically have theory of mind or the ability to put themselves in someone else's shoes. And when that isn't developed, then you start to see other things. But we also ask about like imaginative play. And when you did play with peers, was it like, okay, yeah, you can play with me, but like, we're going to play what I'm playing. You know, I'm going to be the biologist and you could be like my lab, you know, partners or something like that. Or is it more like openness, sharing, and reciprocal? But it's really important. It may not manifest until social demands exceed limited capacities. And this is where people get messed. So like they may be able to like mask or put on or fit in until like middle school, high school, where like girls are really mean, you know, and there's more like for teens, there's always changing social rules. That's why you see in folks who are autistic, they normally get along really well with people who are much younger than them, and then with adults. Adults are very gracious and accommodating to different social styles, and they have more fixed social rules, like this is how you interact. And then, you know, people much, much younger, like babies, again, kind of a similar thing where it's easier to understand versus in the teenage years, it's always changing. And that's where the social demands can exceed whatever capacities or compensatory strategies that they've learned. And I'm spending like a lot of time on these earlier slides, but I feel like this is really important for everyone to understand. And then as far as severity level, there's 3 different types when diagnosing. So it's like level 1, level 2, and level 3, and it depends on their support needs. So again, we do not say high or low functioning because it's very disrespectful for people who are high or low functioning, meaning like high functioning, what do you mean? Like, I don't need any support, I got it all together? Like, no, I still have these challenges. And low functioning, what do you mean? Like, I'm you know, worthless now? Absolutely not. It's about how much support do you need and in what areas. So that's how we differentiate it now. Requiring support, requiring substantial support, or requiring very substantial support. And so you can see this again, the spectrum. Again, it's not linear, but it's more of a pie. And so what that pie looks like will go across the line of how much support you need. But again, the sizes of each slice is going to depend on the person. There'll be differences in social differences, repetitive behavior, sensory sensitivities, and there's a lot more here. Perception, it's just a different way of saying, you know, sensory sensitivities or sensory perceptions, executive functioning, and etc. And again, we don't use Asperger, we don't use high functioning, low functioning, because those terms are outdated and quite harmful. Okay, and again, let me know if there are any questions. And then there are folks who have both ADHD and autism. But as you're looking at a differential between the two, there are also some shared features. So both have, as I mentioned before, some developmental differences. Both will have stimming or self-stimulation. So that could be like playing with a fidget spinner or, you know, manipulating something in their hands. But that self-stimulation actually helps to regulate the nervous system, down-regulate the nervous system, keep things calm. There can also be auditory processing disorder, talking a lot. The talking a lot in ADHD and autism looks different. So the ADHD talking a lot is like kind of interrupting the other person, and they just have to get everything out, you know, before they forget it, or impulsivity, it's like on their mind right now. That autism talking a lot is usually like verbalizing like everything that they know about whatever their special interest is. Like, oh, did you know about da 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 da? And it's fascinating for them. And if they're around their people, it's fascinating for their people too. However, if it's a person who like doesn't care about like the etymology of this particular, you know, insect or whatever species, then they're just like, okay, can we like go back to talking about your homework? So understanding those differences, finding it hard to make friends can be true for both. Being uncomfortable making eye contact with others can be true for both. And with autism, it's like, because you are able to like notice every feature on a person's face, it can be very sensory overload to have to look at a person's eyes, to have to look at a person's face, versus if you're able to look away, that you can focus on what you're saying. And then sleep problems are both, and I told you guys already, 75% of people with ADHD, 75% of people with ASD have at least one additional diagnosis, and then 60 with ADHD and 50% of autism have two or more. So here are the case examples. Did we have any questions before we get to these? Okay, I'm trying to be respectful of the time, and we have until 10:30, correct? Okay, we're good.
Yes.
We're good. Okay, so case examples. So all these are all fictitious names to protect confidentiality. These are real clients from my practice. And I just want to say, like, no two ADHDers, no two autistics are alike. So just because I'm giving you these specific examples doesn't mean that they apply generally across anyone who is neurodiverse. So you may see an example that is very different than what I'm sharing, or they may, have some very similar features that show up. But these are just kind of to get your wheels turning about like what could be going on for the client that I'm seeing in my session. All right, so we'll start with Amanda. She is a 25-year-old engineer, and she was referred by her therapist for ADHD testing because she had depression. And so the working theory was, okay, the executive functioning issues at work could be secondary to the depression, but the depression symptoms were actually under control, but she was still having executive functioning issues. So having a really hard time getting started with things, making mistakes on reports that she was writing, having a difficulty with like getting everything done at once, feeling overwhelmed when she had multi-step projects and those sorts of things. She was struggling with organization and time management, or task management and time management, by the way. Learning new routines and expectations of new team members. She was interpersonally pleasant and reciprocal in conversation. So you would not, just having a conversation with her, you would not think that anything was different or neurodivergent about her. So this was somebody that I tested. This was actually back in 2020, and she had flown down from a different part of the state for the assessment. And she was like smiling and laughing, laughing at my jokes as I try to, throw in a couple every once in a while. And she had actually asked me about, my family and those sorts of things. But during the clinical interview, she shared that she had actually learned scripts for interacting with others when she was in college. So I have this picture of a bar to the left because she would go to a bar when she was in college. And a lot of college students go to the bar to find dates, hook up, whatever. But she would actually go to study others and understand like, okay, well, when someone says this and they have this facial expression, then this is what they mean. And so she was able to get by. During the clinical interview, her IQ was 133, which is 2 standard deviations above the mean. Basically, she was hella smart, very brilliant. And her GAI, which is her IQ taking out the factors that are impacted by attention, so working memory and processing speed, it was even higher. She had a lot of variability within tests for working memory measures and elevations on the CPT, the continuous performance task, which is a computer-based test for attention symptoms. First-gen parents, American parents, they were not open to mental health discussions. So she was from, her parents were from, keep it very broad, an African nation. And they were just like, there's nothing wrong with you, you get good grades. And so it wasn't until she was on her own, paying for her own therapist, you know, working as an engineer, she was doing okay until, again, the demands exceeded her capacity. So she got pulled into a new team and, you know, had these new responsibilities. And the depression treatment, you know, was working, but there were still these issues that she was just like, I think there's something. And thank goodness her therapist was very savvy. So she was diagnosed with ADHD. At the time, I wasn't doing autism testing, so I referred her out, but she would have also met criteria for both ADHD and autism. And here she was, 25, thinking that something's wrong with me, when really nothing was wrong with her. She just needed support in specific areas. This is, we'll call her Asia. She's a 34-year-old arborist. So her job is to study trees. Best job for her. She was loving it. She got tested for ADHD after receiving a promotion at work, where before, like, most of her job was going out, taking samples of the trees, you know, sending them to the labs. Like, she was out and about and physically active. She got a promotion, which she needed because she lived in a very expensive part of the state. But now half of her time was on the computer. So it was writing reports, actually doing administrative tasks, and things really fell apart. And she was just like, okay, I know I'm smart. Like, why am I not able to do something that should be so simple for me? IQ 99th percentile. Again, very smart. This is, you know, a good reason why she was able to accommodate and get by. She was also a pretty anxious person. So typically, you know, you might see in folks assigned female at birth where, or even assigned male at birth, where there's a high level of anxiety. So even if they do have executive functioning issues, so like they're waiting until the last minute to get their, you know, homework done, or they're forgetting things at school or whatever, they get stuff done because that anxiety kicks in, you know, despite the executive functioning issues, and they're able to work really well under pressure. She had no elevations on the CPT. So the continuous performance test, which is the computer test testing for ADHD, it was not sensitive enough to catch her, which is why we do a full battery to see, like, you know, looking at multiple signs during testing. So looking at parent reports, spouse or partner reports, self-reports, like I said, the report card since kindergarten, how she does on the test, and also how she does within the different tests. And so I did diagnose her with ADHD, which was so helpful and eye-opening for her, because she was just like, now it makes sense. Now I have an explanation for my experience. She was an attentive ADHD. And, you know, so this was the person who was quiet and compliant in class. So she didn't get flagged by teachers, but she was daydreaming. So she would miss half the notes and things like that, but she was smart, so she would fill in the gaps. And kind of just as an FYI, there's research that shows that up to 43% of people with ADHD will pass the CPT. So they're missed. So why do we still give it? Because we stick with traditions in psychology, and this is what, you know, professional standards say that we should do. And it is really helpful for folks who, you know, do have, you know, such profound differences in sustained attention and impulsivity that it picks up on it. But again, you don't take one piece of data and do a diagnosis. And again, if you have clients who have been, you know, went for an evaluation and the person said like, oh, well, you passed the CPT, or you didn't do well on, or you know, didn't do poorly enough on the CPT, so you don't have ADHD. You know, multiple data points that you collect, including not only like, okay, she did great on working memory measures, but she'll get one right, one wrong, one right, one wrong, meaning there were fluctuations in her attention within the test. So those are some of the observations that I look at as far as like, this is the same difficulty level. You have the ability to do this, but something's going on. And the person will report like, yeah, this is actually what happens in everyday life. Like half the time I'm, you know, forgetting my keys or can't remember where, you know, I put my phone or lock my keys in the car. Like kind of just as an FYI for me personally, this Apple Watch was the best investment ever because it has the thing to find my phone. And so like at least once a day, I'm like, shit, where's my phone? So I'm clicking, it's like, oh, it's under my pillow, or oh, it's in the other room or whatever. So just as an FYI, there are some external frontal lobes that you can have. Technology really helps us in those ways. Okay, so this is Lena. 17-year-old honors student, IQ 98th percentile, again, a very smart individual, failing classes. Why are you failing classes when you're so smart? School refusal. Problems began when she moved to California. Her parents sent her for ADHD testing. Her younger brother actually was diagnosed with ADHD. Started asking questions. She shared with me that she collected various insects and made jewelry from the insects with resin, and she knew every single fact about insects, things that like, I'm like, that's really amazing. Like, I'm like afraid of bugs. So I would like not be interested in learning these things. She didn't have any friends. In childhood, she did, but not since moving to California. In childhood, she had play dates that were set up by her parents with similar kids. Her brother was diagnosed with ADHD, as I mentioned, and disruptive mood dysregulation disorder. And the younger brother had severe behavioral problems since early childhood. Lena had suicidal thoughts, skin picking, depression. There were no unusual elevations in neuropsych testing, meaning, you know, all the cognitive stuff that we did, like there was like, she's doing great, which is, you know, her IQ would say so. However, what I did was an ADOS with Lena and an ADIR with the parents. And so there are a couple, like I said before, there are a couple different interviews that you can do, ADIR or the MIGDAS. And with Lena, you know, it was so apparent that she had learned these skills and learned these scripts for how to get by. But when I asked her questions about like, you know, why would a person live with their partner? It was very like mechanical and transactional and not about understanding like other aspects of partnership or, you know, the social aspects of like, you know, you guys both love each other and can support each other and those kinds of things like, well, you know, you could split the bills. So, you know, and understanding that. And then part of the ADOS as well is like, you have a picture book. And as they're going along and reading, actually, I probably shouldn't tell okay, I'm not gonna, so anyway, let me not give away, just in case there are some clients that'll watch this recording later, but there were things that I noticed that showed some elevations. And then when I asked the parents about specific things when she was younger and present, so much was revealed. And preoccupation with unusual things. I have a fire hydrant here. So when she was younger, anytime there was a fire hydrant, her parents had to stop and let her climb on it and play with it and those sorts of things. And that's unusual. You know, that's not something that typical, you know, 5, 6, 7-year-olds want to do. But the parents, they were so nurturing. And so there was some shame with the parents, like, kind of spoiler, I did diagnose her with autism. She didn't have ADHD. The parents were like, well, how could we have not seen that our daughter is autistic? Like, how could we have missed it? Because they were so accommodating and so nurturing. Like, yeah, like our daughter's quirky, but that's just kind of how we are. That and the identified patient in the family was the son. The son had taken up so much of their time and attention that when Lena was having these different behaviors or manifesting like a different brain style, she was missed until she was just like, F it, I'm not going to school. It's too hard. You know, I have no friends, you know, and what's the point? Even though her potential is so high. And so finally the attention was able to shift to what's going on with my child and how can we also get her support. So again, with the skin picking, those kinds of things, that's a self-stimulating behavior. It's not OCD. Although a person can have both, but in this case it was not. So Ben is a 17-year-old honor student, again, very smart. Parents sought accommodations testing for school support and an explanation for his challenges. So he was struggling to finish assignments on time. Any task that was given for school, so, you know, read this book, do this report, whatever, he noticed that it took him a lot longer than any of his peers. So a homework assignment may take his peers like half an hour. It would take him 3 or 4 hours. He was also quite forgetful. Kind of as an FYI, he did some sports, but more like individual versus team sports. So he was a swimmer. He had poor coordination. There were early delays in his development. He was quiet. He had, you know, black-white thinking, some more concrete thinking and problem solving. And he disclosed about problems with understanding jokes, understanding facial expressions, and understanding nuances in conversation. His older sister had autism, but was at a level 3 support. She had very high support needs. So when the parents compared and contrasted the kids, it was interesting. Actually, at one point, the mom was like, yeah, I thought when he was younger that he was autistic, but he grew out of it, because they didn't see the same developmental trajectory as the sister, who had such severe regression, needed a lot more support needs. He seemed to be fine. Really, he learned scripts and he learned how to get by and how to mask and how to compensate. But really, he didn't understand jokes. He would laugh when others laughed. And he had a hard time understanding, like, okay, that facial expression means what? The CAT-Q, so that's the Camouflaging Autistic Traits Questionnaire. This is open source. You can Google it and take it yourself. It was very high for the masking that he was doing, for the compensation that he was doing, for all these other things to try to make himself appear normal or appear neurotypical. So what I didn't do the ADIR, which is a parent interview. The parents were alone and I'm asking them questions, because I knew that the parents had this compare and contrast bias with the daughter needing high support needs. Instead, I did the MIGDIS interview, which is the client is there and then the parents are there as well, because I needed the parents to hear their son's experience. That although the son is getting by, although the son gets good grades, he's struggling with these executive functioning issues secondary to autism, and he's really struggling on the social aspects. And so the parents were able to hear, like, oh my gosh, like, yeah, I know you'd go off on your rants, but you've really, cut that down. Now we can barely get you to talk, and it's just like, yeah, I did that on purpose. Yeah, this is actually what my internal experience is. And so it was really a game changer for the whole family, because they better understood where the son was coming from and what the support that he needed. So he wasn't left out, or left to struggle alone. I think this is the last one. So Jennifer is a 27-year-old mother of two, and she's a materials engineer. She started noticing problems at home and at work with emotion regulation, procrastination, organization, attention to detail, unless it was on her special interest. And she noticed that things got worse after having her second child and after the pandemic hit. And so that means that her routine and the ways that she had learned to compensate had shifted. Everything that had transitioned, she had to relearn all these things. Plus, having a second child, now, like, not only are you working and you're having to work from home, but now you're having extra responsibilities, you're having extra things outside of your norm and routine, and she's wifing and mothering and all this. So it was a lot. Again, her CPT was also normal. Her IQ was also high. But looking at her, oh, and by the way, her on the parent forms, parents said nothing was wrong. No, my child is perfect. She doesn't have, anxiety, depression, anything that she's even been diagnosed with. She's fine. Spouse forms were normal as well, but the spouse was comparing and contrasting to like how he was, instead of just like objectively, like, what do I see in my wife? It's like, yeah, you kind of blow up out of nowhere, but it's just how you are. It's just like, okay, well, that's not helpful. So again, multiple data points to better understand the whole picture of what's going on for this person. Reviewing the report cards. The report cards were very, it was a lot of evidence that these issues were happening from very early on, second grade and even earlier. She would forget assignments at home, messy desk at school, so many things, A for the grades, and then teacher comments, talk too much, talk too much, talk too much. I was like, shit, this sounds like me when I was a kid. And what she said was her mom actually worked at the school. And so it was like every day it's just like she had to remind, like, okay, you got your book, you got your backpack. And then, nearly every day that she would have to go back into the classroom, her mom would take her back and get whatever that she was missing. And then, do that check at home, before she went to school. And so there was so much support around the ways that she was having these challenges that they were kind of under the surface, but they were still there. So, and then the mom had ADHD, and we talked about that 76% heritability. So here's a summary list. And again, this is not the totality of, but there are some reasons why you or your client may be missed. So there's already an identified patient in the family. I shared that with the case examples. Academically, they're glowing. So there's no red flags for teachers. Like if you're failing second grade or, fifth grade or whatever, then you're going to get tested by the school, at no cost, actually. The person is a daydreamer. So they're not hyperactive. They're more compliant. Or there's a very accommodating and nurturing home environment. Like, yeah, my kid is quirky, but, these are the ways that we, help with that. Or, yeah, my kid has, these explosive meltdowns, but what we do is a lot of front loading of preparing, like, hey, we're going to do this, at the end of the day, or this is what's happening tomorrow. Hey, you have 2 more minutes before we have to transition to another activity. Okay, we're going to transition to another activity. So using the skills, and they may not have even realized that these were actually skills, behavioral therapy skills that are typically trained to people, but they're doing it naturally as parents. Again, the parents may have normalized behaviors as not problematic. Also, there may be inadequate resources. So maybe the teachers do see that something's wrong, or the parents do see that something's wrong. However, the school's like, okay, well, we can get your child tested, but, there's, 40 other kids who are waiting. So it's going to be, 12 to 14 months. And it's just like, my child will be graduated by then, or it's the summer or whatever. And that, is real and it happens. And, that's often related to the school district. And, depending on the school district, a lot of the funding for schools come from property taxes. And so if there's more, apartments versus home ownership and those sorts of things, all of that goes into place. There also may be a sibling or family member that has more impairing traits or features or needs more support. So compare and contrast, like, oh, they're fine, they're not that bad. Often if they're twice exceptional, meaning they have high IQ plus neurodiversity, then they get missed because they, are able to find ways to compensate or to make up for their challenges or to get by, which is the next point that I have, the compensatory strategies or the masking. And then again, they may be misdiagnosed. And I call these really missed opportunities. So avoidant restrictive food intake disorders or restrictive eating disorders, those are ARFIDs. OCD, ODD, oppositional defiant disorders, trauma disorders, suicidality, all these things before we start asking the right questions of, actually what's your experience like? And then unfortunately, there also may be some shame, denial, ableism. I had some parents who were just like, yeah, my child is, having all these traits and features, but we don't want a label. It's like, okay, but a label can get you, protections and rights under the Americans with Disabilities Act and get your child accommodations and those sorts of things. But, the person has to be ready. Okay, and then I wanted to share specifically with individuals who are assigned female at birth and how features may show up differently. So in autism, they may be super social. So it's not like, oh, they don't have friends or they don't talk to anyone. Like, no, they're really conversational, but it may be one-sided, especially in childhood. So I'm talking about what I'm interested in and not necessarily asking you questions about what you're interested in. I may, take some time to listen, or quiet for a second about your interests, but it won't be that back and forth like, oh, really? Tell me more. Oh, yeah, that happened to me too. Like, the reciprocity that we would typically see. And those assigned female at birth, there's also an intense interest in people, very typically. And so there's a learning of behaviors and how people act and move and tone of voice and, use of gestures and those sorts of things that are learned. And it can even show up as like an obsessive type quality for a particular friend. But again, just understanding like the basis and background for that of this is like a special interest. Also special interest in typical things that people wouldn't flag as autistic. So it's not like, really interested in street lights or, styrofoam, but it's like video games and TV shows, but watching the same things over and 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 over again. And then eye contact may vary. They may have great eye contact, or it could be learned. Meaning like, okay, look at the person for 3 seconds and then look down. So again, asking those questions about like, well, does this come natural to you, or are you feeling like you're having to work a lot or having to kind of have these mental scripts in your head or these directions for how to interact? So again, you need to ask about the experience. In ADHD, it could be being withdrawn, or it could be very anxious. There may be excessive talking that may be how the impulsivity or the hyperactivity shows up versus the typical of what we think of like the, climbing up the wall, jumping up and down in the seat, and those kinds of things that we have seen portrayed in the media for those assigned male at birth who are early diagnosed with ADHD. There's a tendency to daydream. And then as far as the emotional reactivity, there may be some aggression or be very emotionally sensitive. The low self-esteem comes along with being undiagnosed, thinking that something's wrong with you when your ability level doesn't match your performance level, and then there's a gap there, especially if parents or teachers or whatever point out that gap, like, why can't you just, and then fill in the blank. That definitely impacts self-image and self-esteem. Maybe disorganized or messy, late, poor time management, fidgeting, forgetfulness. And these are for folks assigned male at birth too. But the daydreaming, withdrawing, anxious, very sensitive, they, very commonly show up in folks assigned female. Inability to follow through, easily distracted. And I wanted to put on the side of note here in this like purple blue is there's actually a very high autism rate in Ehlers-Danlos syndrome. So that's the hypermobility or like Gumby, where the person has, hypermobile or flexible joints, but then there's also a lot of pain that comes along with that. And one of my colleagues is a functional medicine physician, and she's doing a lot of research about that now, like why are the rates of autism so high for both males and females who are diagnosed with Ehlers-Danlos syndrome. There's also some intersectionality between neurodiversity and the LGBTQIA identities in population. Of note, there are a lot of misses in people of color with ADHD. As kids, they may be instead diagnosed with conduct disorder or oppositional defiant disorder, and as adults with bipolar. But one key, a few different features of differentiating the emotion dysregulation and ADHD versus bipolar, and I'm sharing this with you guys for adults since you work with adults, is that like bipolar is episodic. So you may have mania symptoms, but it's like, 3 to 4 more days, and then like it kind of goes away. Versus the emotional dysregulation in ADHD, it could be like within a day, multiple times a day. It's not just like, it'll be like, 1 hour you're 0 to 100 and then the next hour you're fine. That's not what happens in mania. Mania is like at least, 4 days, 4 to 7 days or more. And then another differential is with the need for sleep. ADHD, you can have hyperactivity or the hyper focus and be up all night, like looking at the latest travel deals and planning your trip or whatever, self-disclosure. But the next day you're tired because you just stayed up all night. Versus in a manic episode, you have a decreased need for sleep. So you may only sleep, 2 to 3 or 4 hours and you still feel energetic. So it's a decreased need for sleep versus decreased sleep, but then you're like hella tired the next day. And then as far as the gender mix with diagnoses, in children with ADHD, it's like 4 males to 1 female, but it's actually 1 to 1 by the time they get to adults. And why do you guys think that is? If you can please unmute yourself. Why is it 1 to 1 with females and males by the time we get to adults with ADHD diagnosis? Gotta.
Van, did you want to say something?
I was just waiting if anybody else wanted to answer, but I had my thought of an answer.
Okay, go ahead.
It was just that maybe by adulthood, potentially all the protective factors or scripts that were working in the places where you can't like shift from are no longer working.
Exactly. If they decided to have children, then those are additional stressors. By adulthood, there's usually less routine and structure of the school environment or the home environment, and there's more autonomy in choosing your schedule. And like you said, like all the ways that they've learned to adapt and to compensate and to function as more responsibilities or more demands get put on, they start to fall apart. So they were there all along. That person was, had ADHD all along, but they, again, were missed. Okay, let's talk about some gifts and opportunities. So it's not all doom and gloom. Yes, we talked about some executive functioning issues. There are some challenges that come along with neurodiversity. However, there are also some really cool things. So special interest. So if you need information on anything and that autistic person, that's their special interest, man, they could be the go-to person for in-depth and accurate information. So for example, when I needed a new microphone for my office, I had asked a person who I knew that like knew everything about, AV and tech or whatever. And he sent me like so much awesome information. I was like, thank you, because I would not have the focus or the, energy or will to do something that I'm not interested in. It's just not how my brain works. Hyper focusing this stuff done. It's great. Attention to details. So going back with the hyper focus, the ADHD, the Attitude magazine also did an article recently about like hyper focus versus flow state, and basically saying like, there's an opportunity for us to train our brains instead of doing like hyper focus that results in like sleep deprivation and then like depletion or a crash afterwards. We can use that hyper focus ability to get instead into flow state. We're like, hey, I'm at a really good flow, but I'm also not forgetting to like eat, hydrate myself, take breaks, those sorts of things. So you guys can look that up, hyperfocus versus flow state with Attitude magazine. And it is in the resources that I provide with this PowerPoint. Attention to details. Okay, so keeping our ancestors alive. There was actually, I might have a slide on this, I'm not sure, but there's research out of Columbia University that showed that there are specific genetic markers that were associated with ADHD biomarkers that were present in nomadic populations. So the folks who lived and survived and are the reason why we're here today is because they were adventure seekers, or they were able to accept the risk of like, yeah, I know we have some water here, but the supply is low. Let's see if we can find more water and berries and food supply, and actually go out. And that it was an evolutionary advantage. If you can also think of the ability to notice like a shadow in a bush, those attention to details, that's also going to keep our ancestors alive and allow us to be here today. So again, there's a reason why there's dominance genetically in the presence of ADHD and autism. Like we need the diversity, and we need neurotypical people as well. It's all coming together. And then the sensitivities. You can have so much compassion for others. I want you to write in the chat, what are some other gifts and opportunities that are typically seen as autistic or ADHD features? Oops. I'll give you guys a head start. Oops, let's go back. Oh no. Okay, so I see connection to animals, directness and clarity. Yes, authentic, compassion, kindness, patient, creativity, thinking outside the box, honest, seeing the world in a different way. Yes, for many adults, I see some become more aware of the neurodiversity after having children postpartum. Yes, yes, yes. Yes, all those things, and the ability to take charge or get things done or see things in a different way. These are all gifts that come with different aspects of neurodiversity. It's not something that we as a society need to throw away or to try to silence or muffle because it's different or makes us uncomfortable. There are some other things on this slide as well. Okay, and then I talked about the evolutionary advantage. So migratory populations had a specific gene, dopamine receptor D4. So encourage greater innovation, less fearfulness about the challenges of new environments. And then there are some famous examples, and I have different notable public figures who are on this slide who are all living with ADHD. So it can be very adaptive, very helpful, but it's also about learning how to harness the benefits while controlling or getting support around the misses or the challenges that also come up with ADHD. And then this is a really cute handout that I give to all of my testing clients about, hey, it's not all bad, but notice this 25 things to love about ADD. It's a little outdated, but ADHD. Excellence in motivating others, always being there to provide a different perspective. What is it? One of them says like Ferrari brain, but with like bicycle brakes, because you can go like, 0 to 100, whether that be with like your ideas or your emotions or whatever, but slowing it down can be a little bit more difficult. Insomnia makes for more time to stay up and surf the net. Far-reaching analogies that no one gets because like your brain went from step A to step L to step Z, and people are still trying to like process step A. But like the people who are your people who get it, they get it. And it's like a lot of fun. And then number 25 is like being highly organized, punctual, and generally responsible. It's just like, okay, I'm just kidding about that one. I did not manage the time well. So here are some self-management strategies and treatment interventions very quickly. So executive functioning strategies, I actually talked about this all throughout the presentation. So people can fall into the trap.
Sorry, just to clarify, Dr. Blied,
Yeah.
we can stick around, like we're available for another
okay,
15,
cool.
20 minutes.
So I'll just
I'm
keep
just
going.
mindful of your time.
Perfect, great. And I set aside extra time for you guys as well. So from the ADHD teen workbook, it says people with ADHD can fall into the trap of asking themselves, why am I so stupid? Why can't I just keep my mouth shut? Or, why can't I do this thing that seems so simple? Especially when they get into trouble. Even when something seems to have gone wrong, you have the power to ask, but what went right? And when you ask yourself that questions, that's when you start to notice what helps you do well. And then you can start to use those to your advantage. So the example in the workbook is this person got like all C's and D's and even fails on the report card except in one class, an English class. And so the parent was like, okay, well, instead of saying like, oh, why'd you fail all your classes? Like, hey, what went different in Miss Johnson's class where you got an A? Oh, well, Miss Johnson, she gives us the homework assignments, written down and in one place, and she doesn't change it. So I know exactly what to expect and when things are due. And, even though I wait until the last minute, like I get things done versus, Miss Williams, she gives us, pop quizzes. And so like, then I'm kind of flustered and can't think straight or, whatever the case might be. So thinking about what went right and then maximizing the benefits of what does work for that person. These are some executive functioning tips that you can use that are also accommodations that people can get after they're diagnosed. So being able to doodle in class, being able to draw or write, it actually helps with attention because you're occupying one part of the mind and also that need for stimulation so that the person can better attend to the lecture or whatever the teacher is teaching. Writing things down in a planner or a calendar, or our phones, our external frontal lobes, using the calendar and then having the reminder alarms and those sorts of things. So not only having the tools, but training how to use the tools and making sure that you're actually using them. Audio recording lectures to hear later. If the person has some processing speed challenges with verbal processing or auditory processing, then if they can hear it later, be able to slow down, pause, those kinds of things that can be really helpful. Structuring your time for work and for breaks and using a timer plus behavioral contingencies. So this is what we call the PREMAC principle. So you include like a variety of high and low interest tasks. So low interest tasks, we don't naturally have the dopamine to be able to like, oh yeah, I'm motivated, I want to be able to do this. But if you say, okay, I'm going to do this homework assignment, work on it for 30 minutes. I'm going to set a timer. And then when that timer is done, I'm going to go play ping pong for 10 minutes, or I'm going to do something that's high interest for me for 10 minutes or 5 minutes or whatever. It trains the brain to, you know, not despise so much that other low interest task, but then also it amps up that dopamine, that reward chemical and motivation to be able to get things done. But having the physical timer there is very important. So you know that there's the end in mind. And then you're actually like racing against yourself. Maintaining a routine is very important. So, you know, if a person who's autistic thrives with routines, I say use your strengths. Your strengths are your weaknesses, are your strengths. So if you need a routine, use a routine. And make sure that, you know, others are aware of that and asking for what you need. Or if it helps you to have lists of things, then have a list, or use an app that actually helps with list making, but then also structuring or breaking down each big part into smaller tasks. And then what's important to have that visually, but then also check off what you've done. So you not only have a to-do list, but you also have a done list. And that is inherently rewarding as well, because otherwise it can feel very overwhelming and very doom and gloom, like, oh, I have these so many things to do and I haven't done anything. Well, actually you can see that I have done these things. And writing down the accomplishments list or the done list, no matter how small that that item was. So like you opened up your computer. Good. You had only 2 tabs open on your internet browser. Even better, you know, so rewarding yourself, training your brain in those ways. Scaffolding and SMART goals. So SMART is specific, measurable, action oriented. So what you are do versus what you're not going to do. What's R? Realistic. So what's actually achievable for you versus like, oh, I'm going to go from, you know, not doing any homework to like doing homework every day. Like, okay, slow down, bro. Let's start, you know, doing it twice a week, you know, so realistic. And then time-based, time-oriented. What's going to be like the accountability for when we can check in on this. Asking for help, like I said, and then having an executive functioning coach can help you with some specific things that you need as you're going along. So, okay, you're applying for colleges or you're applying for grad school. Have that coach to help keep you accountable, disciplined, task-oriented, and time-oriented can be extremely helpful. And as that person is teaching you the tools, eventually they're going to like wean themselves away so that you're using the tools yourself and you're your own executive functioning coach or executive functioning therapist. And as therapists, these are things that you can help to train and help to support in your clients. So what are some other self-management tools? So on my website, the drblied.com/ADHD, at the bottom of the page, there are several resource links, including medication treatments for ADHD symptoms, so executive functioning issues, which again, like I said, are secondary to both ADHD and autism. And there's also non-pharmacological or non-medication interventions. What does that include? It includes the, you know, what we're eating, so our gut health, because there is a connection between our gut and our brain, where there's actually more signals that go from the gut to the brain than opposite. And about 90% of our serotonin, which is the neurochemical that's related to anxiety and depression. And I recently learned like 60% of our dopamine is actually produced in the gut. So if we're getting the green leafy vegetables, if we're doing an anti-inflammatory, so like, cutting down on like cow's milk and things like that, it's going to help us to have a healthier gut microbiome to be able to produce some of those neurochemicals that we truly need to have that balance. Also exercise. There was a psychiatrist who once told me, like, if I can just put exercise in a pill, then like I would be out of a job, because it helps so much with our mood, with our ability to self-regulate, with our executive function, like so many things, just getting, and you don't necessarily have to get sweaty, but just something that elevates your heart rate for a little bit. So that can be like chair yoga and stretch. Oh my gosh, this feels really good. If you guys can just do it with me real quick. Stretching, just something to get some physical movement, and based on a person's ability level. So if you don't run marathons, then don't run marathons, maybe go for a walk in the mall, or, within the neighborhood, if that's safe, or you can walk in place, or, tap your feet or whatever while you're watching a show. So just anything that gets us physically moving. Getting enough rest is very, very important, and can be the opposite of what happens when there is some intensity on studying the special interest, or whatever you're focused on. But again, when we get enough sleep, it actually also helps with our gut health. It helps to balance out our gut microbiome. And then, of course, you see up here in the top left, being out in nature. So doing things that you enjoy. I'm just going to continue to harp on the importance of the gut microbiome, but if you are out in nature and you are barefoot on the grass, the different bacterias that you get kind of just seeping up from there can actually also help your the balance of your gut microbiome, the microbiology, and the diversity of bacteria that we need for healthy bodies. Like, we need a diversity of brain styles for a healthy human race. And then there are also traditional treatments, including psychotherapy, especially for the co-occurring disorders that come along, the anxiety, the depression, the bipolar depression, but also CBT, cognitive behavioral therapy, can help with concrete thinking. So to help you develop more of a nuanced thinking style, or the both and. DBT, or dialectical behavioral therapy, can help with rejection sensitivity that can happen with ADHD and autism, of being sensitive to being rejected socially. So dialectical behavioral therapy includes emotion regulation skills, distress tolerance skills, and mindfulness. And then acceptance and commitment therapy, or ACT, is just like, okay, well, it is what it is. So how can we accept this, but then also still live according to your goals and your values? So identifying what are your values, and each decision that you make or behavior that you have, does this align with your values, or does it go against it? Does it align with your goals, or does it go against it? And then, of course, trauma-focused treatment. Medication is the first line treatment for ADHD. Okay, it's like glasses for your brain. So could I go and have this presentation or go drive without my glasses? Like, yeah, I could, but it would be like an unnecessary struggle. So when I'm driving without my glasses, because whatever, I forgot them or whatever, I can only drive to familiar places, because otherwise I have to be like literally under the street sign before I can see it, or if I'm in class, I would have to be like at the front of the class, or else I'm squinting. And so like, I would be working against my biology of having different or poor vision. Similarly with ADHD, I shared with you guys all the differences in both the neurochemistry, but also the brain structures, where we're dealing with biology. And so biology, medication can help with that, to stimulate an understimulated brain. early intervention with medication, so like, actually under 12 years old, can help to improve brain functioning and protect against some of these comorbid disorders. And what research with youth has shown is that medication plus behavioral interventions, so executive functioning coaching, psychotherapy, has the most powerful and long-lasting impact. So kids who were, I think, around 12 years old, in this study, there were a few hundred kids, and what they had was the folks who had medication treatment plus behavioral treatment, and behavioral treatment only. And this middle group that had both, later on, 18 months later, they were able to actually have less medications because they were able to actually focus and receive what was being taught in the behavioral interventions with the help of the medication. And then they were able to, continue on, versus medication only. It's like, okay, well, now you can control where your focus goes, but like maybe don't have the discipline or the skills to be able to focus on your homework or focus on, your work assignment or whatever the case might be. So you need both. You need the behavioral interventions, training, and the medication. And then there are also interventions such as neurofeedback, or it's EEG biofeedback, which is evidence-based to help with executive functioning issues. So executive functioning issues secondary to ADHD and autism, but then also with emotional dysregulation and issues with anxiety and depression, and a number of other clinical disorders that it can help with. Brain spotting is a trauma-focused treatment. And although it's primarily used for trauma to help, it's a bottom-up therapy, meaning it's working in like not just using talk therapy, but identifying where on the brain whatever trauma is locked so you can fully process it and be able to make sense of it and move forward. But it's not just used for trauma. It's also used for athletic performance and creativity among music artists and so many other things. And you can go to brainspotting.com or just YouTube brainspotting to learn more, including like self-spotting exercises. And I wanted to share that I also have, and it's shameless self-promotion, an app coming out, My Health in My Hands. Had to change the name. Faces of Health is the name of the app that's will be in the app stores later this month, that has brain spotting training, has somatic exercises, has a lot of the things that you would teach your clients in therapy, as far as breathing exercises and grounding and all that. And these tools are available for them to use in between their sessions. So here is, I think, the last slide about like, when is testing actually necessary? Like I said before, ADHD can be diagnosed with a clinical interview and rating scales. However, it's very useful to identify areas of difficulty and impairment which ADHD impacts or makes worse. So learning more about the person's brain style and strengths and weaknesses. And that's also important for differential diagnoses. And autism actually does require formal testing in order for the autistic person to be able to qualify for services. And then testing is also important if the person is twice exceptional, meaning like they would have a high IQ and they would be able to like pass any less formal or unifaceted type of data collection. So again, multiple data points are needed to be able to really understand the picture of what this person is going through. And then, of course, if the person is doing any high stakes testing, so like the SAT, the LSAT, the PSAT, whatever, they have specific requirements for the type of testing that is needed for them to be able to get like extra time on the test or double time, or be able to have it proctored in a separate quiet room or whatever accommodation is going to help level the playing field so the person is not disadvantaged by their different brain style. And here is a review and summary. Oops, let's go back. Let me see if there's any questions in the chat. Someone said, I also read that a low histamine diet, can be helpful for folks who are autistic. Not sure if it's true, but I keep meaning to test it on my body. I have heard the same. I have not tried it on myself, but interesting thing is that the low histamine diet has also been shown to be helpful for people with EDS, Ehlers-Danlos syndrome, which again has a high co-occurrence with autism. So I'm not sure about the evidence-based or literature behind that, but why not try it? Someone said the book, The Psychobiotic Revolution, is super helpful if you want to learn more about the microbiome. Thank you so much for that, that reference. Okay, so in summary, our strengths are our weaknesses are our strengths. So discover your superpowers. ADHD and autism are differences in brain structures and networks, and sometimes chemistry, as I shared. It's not something to be cured or fixed. That is so insulting. We need it as a human race, people who think differently, people who operate differently, so that we all can be able to solve the problems that come up in this life. And the challenges are not about willpower, it's not about spite or pettiness, but again, it's a difference in how folks operate. Learning to identify your client's gifts and areas of challenge can help. So a colleague of mine gave me this quote and I use it all the time. And she says, the gift of awareness is the opportunity for change. So now that you are aware that you have this diagnosis or aware that you have a different brain style, there's an opportunity for getting support where you don't have to struggle in social situations, or you don't have to struggle with being able to start and finish projects. And finally, formal psychological evaluations can help when accommodations are needed or if a differential diagnosis is needed. I end every presentation with this quote. It's my favorite, by Leonard Cohen. It says, ring the bells that can still ring. Forget your perfect offering. There is a crack in everything, and that's how the light gets in. Okay, so let me just break that down, what it means to me. Ring the bells that can still ring. Do what you can, okay? This is important for me living with chronic medical illnesses. Like, there's some things that I can't do, okay, but there are some things that I can do. I'm gonna ring it. Forget your perfect offering. How many times does society tell us, or our parents tell us, that we have to show up in these specific ways? And we're striving for perfection. We're striving to please others. We're striving to be accepted. And Leonard Cohen says, forget that. There's a crack in everything. There's a difference. There's a flaw, if you will, if you want to see it that way, in everything. But guess what? There's beauty in that crack. There's beauty in that difference. There's beauty in the brokenness, if at one point you do see it that way, because that's how the light gets in. The light of your uniqueness and your gifts and your contribution to this world, but then also the light of you being able to show up authentically yourself, which is going to be able to resonate with clients and help you to be more relatable. And so I'm just on a whole nother kind of soapbox right now, just sharing there's beauty in accepting all of our humanity. And so if you don't take anything else from this presentation, I hope you take that's how the light gets in. So thank you all so much. And I am open for questions at this time.
Thank you so much, Dr. Blied, for this very rich presentation. Really appreciate your time and your willingness to also stay a little bit longer with us.
You're
I
welcome.
know a lot of folks have an 11 a.m. appointment, so maybe if we can take maybe a couple of minutes right now, and then if it's possible for us to email you any other burning
Mhm.
questions that people might have.
Absolutely.
Thank you.
Yeah. And I'll just put my email in the chat so that everyone has access to that.
Bye, Van. Thank you.
Any questions, comments? Thank you guys for your comments and your feedback that is in the chat. Put information on the app as well.
I have a question, but it's probably a little too big for the time we have. So I'm going to hold off.
So yeah, we'll just connect.
Very tempted, but I think I'm going to hold off.
Okay.
Yeah. So yeah, any other questions that are briefer that sort of fit our time a little bit better from anybody?
I guess I do have a question. I find that a lot of times sometimes I work with folks who are parents of folks who are neurodivergent, and culturally speaking, I think a lot of folks in my own community have a hard time understanding what autism or ADHD even really is.
Mhm.
So sometimes I want to refer them to like a group, or I'm not really sure how what modalities to use, but I feel like groups are usually helpful, like support groups. I don't know if you have any recommendations on that, or
I do. Yeah. I'll put them in the chat. The help group with UCLA, they have some really good groups. And then they also have a whole program for folks who are autistic at different developmental levels. So for youth and teens and emerging adults. So there's like, for that older population, there's like career, skills coaching, there's dating coaching and all that. So I will pop that in the chat. There's also a movie or a series on Netflix titled As We Know It. And it is so exceptional because it shows a broader diversity of folks who are living with autism spectrum, and it's played by people who actually have autism versus these very stereotypical like repetitive images that we get of someone who is typically skinny white male who is robotic in their voice and doesn't care about friends, and like that's not autism. I mean, or that's just a very small slice of folks who have autism. But this other portrayal, I think, is a lot broader and more representative, and I love it. And it was actually featured in the New York Times as well, as like, finally, someone got it right. So I'm going to put the link to the New York Times article along with the resources for ADHD. Oh, As We See It is what it's called. So please click on that before you go. So Advance LA, the UCLA Peers program, and then Kaleidoscope is, it's through the help group, is for autism plus LGBTQIA, which I explained that there's, a high correlation between the two. It's a really good show too. I love it.
Well, thank you so much. Really
You're
appreciate your
welcome.
being here and taking time out, and learned so much. I have so many notes and really, really excited to follow up on a lot of what you shared today.
Awesome.
Thank you.
Thank
Really
you
helpful
all
for us.
so much for having me. And if you have any questions that pop up later on, please do feel free to email me and I'll get back with you.
Thank you, Dr. Blied.
Okay, thank you all.